bienvenidas, bienvenidos los que nos acompañan a otro seminario más de AMA Women, iniciativa de AMA USA. Estamos aquí muy contentos de, bueno, terminar el año ya del periodo 2022 y tenemos una invitada, bueno, muy especial. Tenemos aquí a la doctora Nayeli Salazar de Noguera. Les voy a hablar un poco y brevemente de la agenda que vamos a llevar el día de hoy. Bueno, la agenda del día de hoy tenemos, como mencionaba, Nayeli Salazar de Noguera. Ella nos va a hablar acerca de un tema que aún está teniendo mucho impacto en nuestra comunidad. Y bueno, el tema en especial es Latinx Mental Health in the Time of Coronavirus. Vamos a cubrir varios puntos importantes. Nayeli se va a enfocar en los resultados que hubo en el estado de New Jersey acerca de las infecciones, hospitalizaciones y muertes. También el impacto del COVID-19, por supuesto, pre y post. Y bueno, las oportunidades para poder mejorar el bienestar mental, que ha sido obviamente un tópico que está día a día en la mente de nosotros. Entonces, con eso me gustaría nuevamente darte la bienvenida, Nayeli. Muchísimas gracias por también ser miembro de AMA USA. Y con esto me gustaría también informarles que la presentación se va a dar en inglés, pero ustedes van a tener la oportunidad de hacer sus preguntas en español en el chat al final y también durante la presentación. Nayeli va a hacerles cuestionamientos si tienen alguna duda específica sobre el tema que va a cubrir. Y con eso me gustaría compartir con ustedes un poco de la historia de Nayeli. Voy a leer información sobre ella en inglés. Entonces, bueno, tenemos a Nayeli Salazar de Noguera. Ella, bueno, tiene un degree, a PhD en Urban Health Systems de Rutgers University. Es the State University of New Jersey and the New Jersey Institute of Technology. También tiene un Masters of Arts, Translation and Interpretation, Spanish, English, Spanish, de la Universidad Autónoma de Guadalajara, México. Cuenta también con su Bachelor of Arts de Rutgers University. And Nayeli is a Program Management Officer for the New Jersey Department of Health, Office of Minority and Multicultural Health. She heads the COVID Community Corps, an outreach initiative to increase public confidence in and uptake of COVID-19 vaccines in underserved communities across all the state of New Jersey. Mrs. Salazar de Noguera has recently defended her PhD dissertation titled New Jersey Latinx Mental Health in the Time of Coronavirus at Rutgers, the state of New Jersey, and NYIT. Nayeli's areas of research includes bilateral health systems comparison, U.S. acculturation, immigrant health, and health communication strategies. Mrs. Salazar de Noguera holds a master's degree in translation and interpretation, as I mentioned, from Universidad Autónoma de Guadalajara in Mexico, and a Bachelor of Arts in Rutgers as well. Nayeli has functioned as project specialist for the U.S. Senate, consultant to the government of Puebla, Mexico, consultant to the Mexican General Consulate in New York City, senior executive associate for the dean at Rutgers School of Nursing, and was a state fellow for New Jersey Governor's Office, Office of Communications as well. Nayeli was born in Mexico City and currently resides in New York, New Jersey. Nayeli, bienvenida, qué honor y qué orgullo. Muchísimas felicidades por tus logros. Y con eso, el micrófono es tuyo. Go ahead.
Muchas gracias. Solamente quería preguntar si la gente, si los participantes prefieren que hable en español o en inglés. Obvio, la presentación está escrita en inglés, pero así podemos también comunicarnos y podría ser una presentación bilingüe. Si pueden alzar la manita, si prefieren en español, por favor. Bueno, voy a compartir mi pantalla, le vamos a hacer en inglés entonces. Okay, I hope everybody can see this. So again, Nayeli Salazar de Noguera, I am a joint PhD student, or was a joint PhD student with Rutgers University and NJIT here in New Jersey. My program was affiliated with the School of Nursing. However, I'm not a nurse. I also wanted to quickly say that my presentation here only represents my PhD work. It does not represent my work at the Department of Health for New Jersey. So that being said, everything that I say here is representing my dissertation study work under Rutgers University. So the presentation today is going to be composed of 6 major areas. So we're going to quickly talk about New Jersey, some demographics, some information related to COVID-19. I think it's very important that we talk about mental health literature. This is information that we had studied to get to this presentation and also to the study, right? This is information that I reviewed for many years and then decided to utilize this information, create something that was going to help meet the gap where literature was lacking. I'm going to talk about my conceptual frameworks. So this is information, these are the frameworks that I utilize to form the study and then ultimately go back and compare it to the results. Talk about my study methods, my study results, and open discussion for opportunities of where we are as Latinos, as Mexicans, and mental health. I hope that everybody enjoys the presentation and gets good information and brings it back to their communities and hopefully begin the work on healing post-COVID-19. So going back to information, so I do want to note where we are in terms of New Jersey, right? I don't know where everybody is here. Maybe you can put it in the chat. So we are located in New Jersey. As you can see, we are part of the tri-state area. We're a small state. We're small, but we're very mighty, big in character, big in personality. We are part of the 13 colonies originally. And I do want to say that Ellis Island, the Statue of Liberty, are actually located in New Jersey, not New York. So this is something that I think people should know when we talk about New York or the Statue of Liberty being the gateway, including New Jersey, into the U.S. For traditional immigrants. However, as Mexicans, we know that we're coming in from a different border or a different area of the country. In New Jersey, we are composed of 9.3 million individuals. As you can tell here, that's comparison to the U.S. Demographics of 333 million individuals in the country. And then leading over to who is foreign born, approximately 23% of the population in New Jersey is foreign born. That means they're not born in New Jersey or the US, they're born outside and have been naturalized. 57.3% have been naturalized, so they have become US citizens. When we talk about median household income, you can see that New Jersey is actually at a higher income compared to the US median, being 69,717, and New Jersey having 89,296 per household. Additionally, when we talk about health insurance, and this is an area for growth, as you can see here, the US is actually beating us when it comes to, the US has a higher rate of no insurance coverage versus New Jersey with 7.2 and the US 8.6. In terms of employment rate, New Jersey has an employment rate of 60% versus the US at 58.6. So as you can say, I would say that New Jersey is leading in several areas, and you will see that further in the presentation. Now moving on to New Jersey and Latinx community. New Jersey, again, is 9.3 million residents. When we talk about population growth, between 2010 and 2020, we've actually increased almost 6% in population. And when we talk about percentage of diversity index, we have also grown several percentages from 55 to 61, 6%, again, in diversity. And you can see here some ages in changes in ages with individuals who are under 18 decreasing while adults are becoming greater in age. So what does that mean? That means that we have a bigger workforce, but at the same time, that means that there's a need to take care of elderly or individuals who are retiring, right? So that's when we talk about government and what that means for health and human services. Moving on to the Latino population, we are close to 22% of the whole New Jersey is Latino, with Puerto Rican, Dominican, Mexican, Ecuadorian, and Colombian, and then moving on to Cuban being the top populations or nationalities represented in the Latino community here in New Jersey. As you can see here, the population for Latinos has increased 28% in 10 years, and that's compared to non-Hispanic growth of 0.7%. So that's huge. And you can see here in the map that I depicted, you can see here, these are the counties. So New Jersey has 21 counties, and these are the counties that have 20% or higher of Latinos represented. And as you can see, most of them are up north, with Essex, where I'm located today, Newark, Essex County, 24%. And Hudson and Passaic, as you can see here, at 40% or higher, which is great, When it comes to New Jersey citizenship and frontliners, I want to mention what that meant here. So approximately 1.6 million people live with families with at least one non-citizen in their household. That's in New Jersey, and that's huge, right? Because that means a lot. That means a lot for healthcare. That means a lot for immigration, for education. It can go into any ways. When we go into immigrant frontliners during COVID-19, 29% were working at grocery areas, 30% were working in transit, 31% in healthcare, 56% in cleaning buildings. So you can tell that these are the frontliners. These are the people who were out working while we were out, while we were at the house quarantining. Something to note here is some important key points that were happening in the pandemic in New Jersey. So as I mentioned, New Jersey is in the tri-state area. New Jersey was at the epicenter of the US coronavirus pandemic at the beginning because of our location, because we are connected to New York. We also have an international airport, Newark International Airport. We have a port. So, we are an entrance into the US. And give me 1 sec. I just have to close my door. My apologies. My cats are jumping around and are distracting me. So now that I've closed my door, March 4th, 2020, New Jersey had its first COVID case in the state. Moving on to March 9th, 2020, Governor Murphy declared a state of emergency and public health emergency for New Jersey. March 11, 2020, who declared a COVID-19 pandemic in New Jersey? April 14, 2020, New Jersey had its first, New Jersey's hospitalization peaked to 8.3 thousand individuals in the hospitals due to COVID-19. And in December 15, 2020, we had our first COVID-19 vaccination administered at University Hospital right here in Newark, New Jersey. June 18th, 2021, New Jersey, and this is thanks to my colleagues in the State Department of Health, were able to get New Jersey 70% fully vaccinated in June 18, 2021. COVID is still here. COVID is still, we're still in the pandemic, even though people don't want to acknowledge it. And I think the only way here to get fully protected against COVID-19 is to get vaccinated or to prevent mitigation strategies to prevent COVID-19 transmission. So going into COVID-19 burden for the Latino community, New Jersey has experienced over 1.8 million confirmed cases, 32,000 confirmed and probable deaths due to COVID-19. When we were looking at what that meant for Latinos and whites, right, and non-Latino whites, and this is something that in research we always look at, is who is the dominant community, or who is the dominant, who is least vulnerable, and that's non-Latino whites, right? So when we were comparing it to Latinos and the white community here in the country, we found that 1.5, that individuals, the Latinos were 1.5 times more likely to become infected, 2.4 times more likely to be hospitalized, and 1.9 times more likely to be to die from COVID-19. And as you can see here, I gave some information back in 2020 at the beginning of COVID-19. So, you know, we were able to bring it down in 2022, but you can still see that Latinos are still at a higher burden for COVID-19. When we adjusted information for COVID-19 per 100,000, you can see that Latinos, Hispanics here are the most vulnerable to both mortality, hospitalization, and infection. And that's compared to Asian, Black, and white communities. So now going into mental health literature, and I think this is very important because this is how I started conceptualizing or started understanding how I was going to formulate my study. So when it came, and I don't know if anybody here is familiar with the Latino immigrant paradox, I'll stop at different sections after this and you can ask me questions, but for now I can't really see you. So I'm just going to go ahead and explain what these terms mean, right? So the Latino immigrant paradox basically says that individuals who are foreign born, meaning people who are born outside the United States, are more physically and mentally healthy compared to Americans who have been here for, you know, since the US, but also for immigrants who have been here for several years and into generations. So what does that mean? It means that there's resilience when it comes to immigrants, and especially Latino immigrants. Now, going on to disorders by nativity, we also know that the more time we spend in the US when it comes to mental health disorders, there's higher rates of psychiatric disorders specific to depression, anxiety, and substance abuse. And you'll see some information there as I move forward. So this is a study that was conducted by Margarita Alegría, who is in, I believe, Harvard University. And she studies a lot on Latino immigrant paradox and is trying to see the differences in nationalities. So as you can see here, this is what the US born versus immigrants. And you can see here that this is any anxiety on the left side, and this is substance related anxieties. So as you can see, Mexicans who are in the blue side stay consistent when it comes to disorder rate compared to the other communities. So Mexicans, right? So we know that Mexicans stay consistent when it comes to mood, anxiety, and substance abuse disorders. So the more time they stay here, it stays consistent, while the other nationalities change a little bit. Cubans and other Latinos, it's only protective against substance abuse disorders. And when we talk about lifetime disorders related to mood, anxiety, and substance abuse disorders, Mexicans are the second community who are more prominent to disorders, Puerto Ricans being the number one. And as you can see here, we're at 30% versus Puerto Ricans at 37.4%. And Cubans following as third, and other Latinos considered at fourth. So now this is related to behavioral health, right? So when I study mental health, I have to also understand how people view, perceive, and utilize the services that are available to them here, but also in Mexico. So I've had the opportunity to do investigation in Puebla, in Oaxaca, and because those are the communities that are the largest Mexican communities here in New Jersey, with the Poblano community staying in Passaic, New Jersey, which is in the north, and the Oaxacan community being in Middlesex County, New Brunswick, which is in central Jersey. And then moving on to South Jersey, and I'll talk a little bit about that. It's the migrant communities, the farm workers, because we are the garden state and we do have lots of gardens and farms in the southern area. So you will see a lot of temporary migrant seasonal workers coming in the south. Anywho, coming back, you can see here that Latinos are less willing to use mental health services. So we can see here that less than 1 in 11 US born seeks mental health services. And then when we talk about immigrants, right, Latino immigrants, it's 1 in 20. So that's a huge disparity, right? Just by saying I'm US born versus I am an immigrant. Going all over to how much Latinos have health coverage, approximately 31% of Latinos populations do not have health coverage, right? And that's in the US. And we saw before when it came to just individuals not having health coverage. 34% of Latino immigrants and also 45% of Latino non-US citizens are uninsured. And those are huge disparities when it comes to healthcare access and utilization. So going and thinking about what are the barriers? Why aren't people going to get health services? And this is just specific to health services. We have cultural barriers and we have structural barriers, right? Individuals don't believe in healthcare, right? They have cultural beliefs, religious beliefs. There's resistance to treatment. Maybe they don't want to acknowledge that there's an issue. There's stigma, perception of others, lack of readiness for change. Some people don't want to face reality and make that step. Educational attainment. We know that educational attainment is a huge predictor to utilization of healthcare, and English proficiency as well. And you'll see that in my results as well. When it comes to structural barriers, so we're talking about the infrastructure, right? So when we talk about health systems, it's what's the local health system, but what's the state, and then moving on to the national, what's available. So we're talking about insurance and inability to have insurance, lack of coverage due to residency status. So we know that some individuals aren't born in the US, right? So there's a certain time where they can get healthcare coverage as immigrants, right? But in addition to some of them don't have in the US a lot of the health insurance is employer based. Maybe they don't have a full-time position that provides that type of coverage. Inadequate transportation. So there's a lot of individuals who live in certain areas that are rural perhaps, or aren't able to get to their appointments because of the lack of infrastructure in terms of transportation. Inability to attend appointments due to our availability. Again, we know that Latinos, especially immigrants, work sometimes 2 or 3 different jobs, and their time just does not allow them to get to that doctor's appointment. Access to or knowledge of regional services. Maybe the individual has just been in New Jersey several years and doesn't quite understand how to navigate the complexities of not just the insurance, but also the services that are provided. As we know here in the US, it's very specialty focused, right? Versus perhaps in Mexico, where it's socialized medicine and socialized healthcare, and you just go somewhere and you get all the attention that you need. Fear of deportation is huge. That's something that we saw here when it came to COVID-19 vaccination, that a lot of individuals were very scared, not only for themselves, but for their family. A lot of Latinos come from mixed status families, meaning that some are naturalized or residents, or, and some are not, and that's okay. But that's definitely one of the biggest barriers when it comes to utilization of healthcare services. Now, talking about mental health services, we know that individuals will see a general care provider, will also even see social workers, counselors, religious individuals before they will go to a specialty mental health provider. Meaning they will not go to a psychiatrist. They will not go to a psychologist. They will not go to hotlines or mental health professionals before they reach out to their general practitioner, right? Their general doctor, even an occupational therapist. I thought that was very funny that you will ask for mental health service advice to a occupational therapist that has nothing to do with mental health before you actually went to see a specialist. And then moving on to Association for Mental Health Services, we know that, again, the English proficiency, university level completion, and confidential treatment away from the family, meaning that the family does not know that you are seeking these services, will yield greater results when it comes to engagement and also utilization of services. And then going on to usage of associations in primary care, because I always look at different components, not just the mental health services, but overall healthcare utilization. We know that women are gateways to healthcare and primary care. These women are promotoras, they're navigators, they'll tell their husbands, hey, viejo, you gotta get that checked out, you know, you're not doing so well. Spanish language care, we know that if services are available, not only in Spanish, but hopefully bilingual and into other dialects, perhaps, because we know that Latinos speak other dialects, right? And other languages. They will be more engaged to using primary care services. Affordability and accessibility and level of pain. Individuals will not go to the doctor, Latinos, unless there are very, you know, they've reached the level of pain where I'm going to the emergency room. And that, you know, and again, that goes back to primary care and preventative services and also knowledge, right? Knowing that, hey, something's wrong with me, let me go get checked out now instead of later. When it comes to females versus males, we know that when it comes to mental health, females, slightly higher levels of depression in males compared to females, but it's basically the same. When it comes to suicide ideation, there's a huge discrepancy. And suicide ideation doesn't mean I'm going to commit suicide. It's that I have thoughts of hurting myself or possibly, you know, committing suicide, but not necessarily engaging in the act of it. So these are the thoughts. We know that females compared to males in this particular study, 69, almost 70% to 21%. So it's huge. When it comes to generational differences, and you know, and I have to go into each little nook and cranny because this is how I look at things. You have to, Latinos are, you know, there's 21 countries represented in Latinos, but within Latinos, there's differences in not only immigration status, but also in generations, in communication, in education. So there's so many ins and outs, and you'll see that in my structure here. But US-born Latinas are 5 times more likely to be diagnosed with major depressive disorder than compared to Latinas who have been here less than 5 years in the US. So meaning that the more time you're spending in the US, the more likely you are to show signs of depression. Same thing goes with foreign-born Latinas are 3 times more likely to be diagnosed with major depressive disorder 11 years after being in the US. And females and older Latino immigrants are have higher levels of acculturation stress and are more vulnerable to depression. So we know that acculturation stress, meaning the pressure to, you know, to live in a different country, to perhaps experience what it means to be an outsider, sometimes discrimination. So everything that encompasses becoming an American, right? And managing 2 cultures, 2 identities within the United States. Females and Latino immigrants are more susceptible to becoming depressed. And parents' low socioeconomic status, meaning individuals who are below the poverty level, educational attainment, and who are persistent fear of deportation. So we are talking about the most marginalized people in our community or the most vulnerable due to their immigration status, individuals who came here undocumented, individuals who remain undocumented will have more symptoms of depression, anxiety, and PTSD. And this is a huge area of study when it comes especially with DACA students, with individuals who, you know, again, are in that vulnerable population due to their immigration status. Family and social dynamics, as you can see here, family cohesion, meaning how tightly knit are you with your family, can reduce the likelihood of general anxiety disorder. So as Mexicanos, we know that you know, we come from big families, and that cohesive, that collectiveness, that being aware of each other can be a huge protective factor against anxiety. But as you can see later on, it could also be turned as something else depending on the dynamic of the family. Retention of an ethnic identity, meaning I want to stay or keep my roots as a Mexicana, as a Latino here, but at the same time participate in a larger American, US American entity, has been linked as a stress buffer, right? So being proud of who you are, being proud of your identity will reduce social discrimination. Will reduce the anxiety that comes with social discrimination because you are an outsider. It will also, lower levels of withdrawal and depressive symptoms can be reduced by ethnic identity, by keeping those roots, by keeping that language, and you'll see later on. And this is something that I particularly enjoy studying. I am foreign born, I'm Mexican. I grew up with I grew in a very traditional American middle class community, Caucasian white stepmother, Mexicano father. So in my household, I had these two identities, right? And then moving as I got older and learning about other Latinos, I found that it was a very growing area for me. I was able to understand that my language, my foreign entity gave me a strength that perhaps my American counterparts did not have, because they've been here for many generations. Lower levels. All right, and then moving on to Latino males. When we talk about Latino males, negative interactions with family members predict the likelihood of major depressive disorder and suicide ideations. So this is what I was talking to you about. So we know that in males, right, the family dynamic, if it's not something that's solid, solidified, a good family, a healthy family structure, and healthy dynamics can lead to these two mental health disorders, or at least illness of them, or showing symptoms of it. And then perceived discrimination and or family conflict can also predict suicide ideations. This is something that we see a lot in youth, right? So this is something that we see in adolescents as they're trying to become adults, and perhaps they have gender roles, or perhaps they have family obligations, and they're trying to come out of these particular settings and be their own, and try to find themselves in these two worlds, and also feeling discriminated, can predict suicide ideations. So I'm going to stop here because I know that's a lot, and I want to ask anybody if you have questions, and then we'll restart from where we are. Y si por favor pueden poner sus cámaras, me gustaría ver sus caritas, saber quién es quién. Muchas gracias por estar con nosotros esta noche.
Don't be shy. Okay, we have Johanna. Johanna has a question.
Yeah, no problem.
¿En inglés o en español?
Como gustes.
Ok, en inglés porque creo que lo dijiste en inglés y yo tengo las palabras. But I'm really curious about the differences that you showed us between US-born Latino people and then first generation or foreign-born immigrants. And I'm curious to know, what do you think impacts the differences in health outcomes? Like, why is it that people born in the US have, worse outcomes for some of them?
So that's something that I try to study, right? Because there's not enough literature. That's a big gap in literature, right? Knowing, and it's a different formula as we were talking about before. All right, Joanna, you're in California, right? Hesse is in New York. I'm in New Jersey. My migration experience is very different from yours. And additionally, my family dynamic, even in Mexico, is very different from yours, depending on where I'm coming from. So it's a whole context, right? And you'll see in my results, and if you just hold on a couple more slides, you'll see what I actually found, because I did try to figure out, all right, when did you come in? Trying to figure out, how many people live in your family, like doing all these stories in my head, and ultimately comes down to, you cannot predict it. You can predict a little bit, but you really have to go into qualitative data, right? So that's going into the houses, going into the interviews, understanding that dynamic versus, all right, you came here in 1960 during the Bracero, movement. You were able to get it goes further. And so, I'll just tell you now, I found that foreign-born nativity is a greater predictor, at least for this study, than US generation. And that's something that I found statistically. So again, it's going back and then looking into the actual data, and you'll see that in a moment. Beatriz, do you have a question?
Yes, thank you so very much for your excellent presentation. And just for your information, right here in Virginia, I have been for decades very involved with the Virginia Health Department. And surprisingly, the statistics and the studies seem very similar. And what we actually discovered was that the excellent health of first immigrants depends very much on their food intake. Usually when people come here, they love to eat what they used to eat at home, which is fresh foods, fresh vegetables, and they don't actually consume a lot of processed foods. And that seemed to have a great impact on the health of individuals. And another thing that was surprising was the fact that, in spite of the fact the Latinos in Virginia that are, say, undocumented immigrants, despite the fact that they don't have health insurance, their health and the outcomes, other than, say, catastrophic accidents and so forth, basically they are puzzling to others as to why is it that they're so well off. And one of the things that when I make presentations, around universities or communities, one of the things that I point out is that when we see immigrants in the United States, we see basically the survival of the best of the best. And we see that people endure coming across, and those that arrive here survived hardships and all of those things, thanks to basically the health and so forth, the conditions that they had prior to their experience arriving here. And so I wanted to see if you could share in regards to the undocumented populations, the ages that were studied and so forth, because we see that, they're younger, they're stronger, they have survived. So therefore their condition to begin with was excellent.
Yep. So you'll see that in my study results. I'll share more information about who my participants were. But one thing that I do want to mention again, the the importance of doing a localized study. You know, it's difficult to generalize all Latinos,
Right.
in the East or the West or in Virginia and New Jersey. We're all very different, and at the same time, we're similar. So, you know, it's taking what you learn here and applying it, you know, and doing your own research and coming out with your own data so that you can use that as to modify policy, to have a stronger sense. It's evidence-based practice, right? To push your government to do more. One thing I do want to mention before we go to Gilberto is social determinants contribute, right? So social determinants, it's what's happening in your area, contribute to approximately 55% of an individual's health. So how you're navigating, what you're eating, all that kind of stuff. With another 20% attributed to medical care usage, meaning that the usage of health systems is important, but it's not as important as what's happening in the area or the residency, right? We always say when it comes to healthcare, just don't tell me your municipality or your town or your state. Tell me your zip code, and I can tell you what's happening there. And 5% is attributed to biology and genetics. So contrary to your belief, you know, only 5% of your health outcomes is related to your biology and your genetics. And then another 20% is attributed to your actions and health-related behaviors. So that says a lot, right? That says that the environment plus the individual has a stronger outcome than the usage and the genetics. And I think that's huge when it comes to Latino healthcare. And I think that's something that is huge when it comes to immigrant behavioral health. Gilberto, por favor.
Yeah, hi, Nayeli. Thanks so much. You're a star. You have a lot of great data, and I'm just really proud of what you're doing. It's fantastic. We need more studies like yours. One of the things I might, you know, in the 90s, a member of AMA USA, and I'm not sure if you know him, is Dr. Sergio Aguilar Gagiola. And
No.
Dr. Sergio Aguilar, actually, he used to work for Fresno State at that time. And he did a study, it's called MAPS, M-A-P-P-S. And Joanna can probably get you his contact information, but you know, he actually did a study where he, in the US, in the Fresno State, I'm sorry, the Fresno Valley, that valley, Central Valley, excuse me. And he had a pretty large N, and he took Mexican immigrants who had migrated from Mexico to the Central Valley. And then he found a similar comparison study in Mexico City. And he followed those individuals, right? So I guess I can put my fingers here like this. He followed them like all the way, like the timeline, right, of the length of time. And he then actually found that Mexican immigrants living in the Central Valley, like at around year 8 or year 9, they actually started having the same affective disorders as the US born Latinos, right? So your 1 in 20, 1 in 10 is really spot on with what, you know, those folks are saying, that it would be fascinating that if you could get his study results, and I'm sure Johanna can get Dr. Gagiola to share his study, because I think it would really inform like what you're finding, which is, I'm really interested and intrigued what you found with your group. And he basically found that there were basically protective factors and risk factors, and many of the protective factors in his study were really about pues el familismo, no, pues que la gente pues está conectada, right? The people are connected to each other, and that the local community served as that buffer, right? So los grupos that you have a lot of, like in Chicago, you have La Casa Michoacana,
Right.
and you have the different identity groups. So like identity is so important in making sure that people have their good mental health. And Alegría, which I'm serving on a consultant team of hers right now through the Disparities Research Unit at Harvard Medical School, we're doing, like, I really like what you said about the localized study. She's doing, and we're doing a study with 340 Latinx youth in our community, looking specifically at those factors that impact good mental health. So if Johanna can help you connect with Dr. Gagiola to get his study results, I think it would like totally just confirm what you're saying. So I just really affirm what you're talking about. So thanks.
Thank you so much for sharing that. I would love to be connected. I would love to look at different parts of the US and see what other findings, individuals specifically and during COVID, and then moving on to longitudinal studies, 10 years later, 5 years later, what does it look like, right? I think would be really interesting. I'm going to continue, and I'm going to share my screen since I do not see any more hands. And let's move over to conceptual frameworks. So these are the frameworks, and there was 4 major ones that I utilized to create my study, right? As you can see, this is the social determinants of health conceptual framework. You can tell the socioeconomic and political context, right? I always think about, okay, this might be the border, right? So what was happening, or here, the border here, what was happening with government, what was happening with public policies, culture and societal values, and how did that transition to socioeconomic position? Really, are you middle class? Are you lower class? Are you below poverty level? Are you above poverty level? Then going on to material circumstances, living conditions, food conditions. Is there ability for fresh fruits in that area? New Jersey, we're going into a cold area. We're not going to have those blueberries and fruits, fresh fruits that we have. So then we have to go and get import food from different areas that might not be that quality of a local raised produce, right? Behavior and biological factors, what we're talking about. How do people move around their environment? The psychological factors, psychosocial factors. What's happening? Is there discrimination? Are there issues happening at home, in the school, in the work environment? And this is something that I did test, which is the degree of separation from the individual in the workplace for COVID burden in the workplace, in the household, in the extended family. So you'll see some of those results later on. And then obviously that's always leading on to the impact of equity in health and well-being. This is a framework for understanding the social determinants of mental health. So this is that structure you just saw, but then moving on to mental health, right? What's happening? So public policy, social norms, and how is that leading to poor or good mental health, right? Because you can have, when we talk about mental health, it doesn't have to be bad. It can also be good. We can have resilience. We can have self-efficacy, which are some areas that I studied under this study. So moving on to stress, high-risk behaviors, poor choices, reduced options. Then we go on to, and I'm flying through this because I really want to get to the results. This is Barry's acculturation. So moving on to like sociology, right? How are people, which was the initial intent of my study, is acculturation in mental health, understanding how people navigate through 2 identities and how do they bridge, and the different aspects of acculturation. Used to be known as assimilation, and that's a older term that only talked about what American environment wanted, right? Was for us to all stop speaking Spanish, for all of us to try to look for the American dream and move to the middle class. So you can see here that this is culture A, culture B. How do individuals understand it psychologically? I always think about people who can code switch, right? There's a lot of people here, right? Gilberto, perfect English, perfect Spanish, right? I am American, but I'm also Mexican. I am, I can, be in different, I can talk in different registers depending on the context. As I like to call them, peacocks, right? We change depending on the environment. And that's known in this type of work that biculturalism is really where the best mental health is, right? Individuals who have a strong grasp on both identities, not only the Latino or the Mexican, but also the American, understand how to navigate through the systems in different levels, have better mental health outcomes than someone that rejects their identity of origin or ancestry, and then only promotes one, right? This is something that's very, very interesting. Alejandro Portes, Paths to Mobility Across Generations. So he says that there's 3 major pathways to American mainstream, right? So as you can see here, there's 3 major components: human capital. So what Gilberto was talking about, the networks, right? The ability not only to have, good understanding of the system, and it could be education, healthcare, whatever it may be, but also of the culture and support system. So you were talking about the nonprofit that is very prominent, and it's an area where we'll get information. So the information hub here in New Jersey, we have Mi Casas Puebla and a lot of other nonprofits that are related. And obviously the Mexican Council does a lot of outreach in New Jersey and New York. And, we get a lot of that connection, and also from our Mexicanos from New York. Family composition, right? What's going on with the family? Is there a mom, dad present? Modes of incorporation as well. How are we incorporating our ethnic communities into our daily life, right? So basically, he's saying that if you have 2 out of these 3, you're going to be successful in the US, right? In terms of social mobility. If you do not, then you're going to stay stagnant. You're going to have downward assimilation. You're going to have, individuals who kind of fall out of plane and lead to, gang violence, subordinate manual jobs. Basically, you stay at the bottom of the hierarchy in the US. So these are the 4 conceptual frameworks that I utilize to study, to incorporate in my study. This is the framework now incorporating what I'm studying. So you can see here, these are the areas in the highlights that I incorporated into my study. And then moving on to my methods. So here, the idea was to have 300 Latinos in New Jersey, right? And I wanted to break it down by generations. 1st, 2nd, 3rd generation, everyone's going to get 100. COVID hit. Obviously, there were social restrictions. It was difficult to recruit people only in the social medium. It was cold. So there was a lot of barriers when it came to recruitment. However, I did get 234 surveys, but only 156 individuals did the mental health screenings, which was the completed study, right? So there was 4 major sections with 134 questions. I know there was a lot of questions, but I needed to know everything. I needed to grab as much information as I could. I have people's contact information, so I do plan to connect with them moving into the future. But the first part is just getting their general demographics. And again, not only where you're located in New Jersey, it's where did you come from in your country of origin, not just Mexico, but Colombia. What is, when did you enter the US? When did you enter New Jersey? At what time period? Because a part of it, a lot of it is understanding immigration law, and also looking at, did these individuals alternatively decide to stay here, go back, come back, become a US citizen, not become a US citizen. There's a lot going on, a lot of moving parts. Then the binational acculturation scale for Hispanics. So this is huge. This tests how individuals speak a language, how individuals communicate with their friends, with their family, what they're doing in terms of radio, television, their choice of language, right? And other identity components. And then moving on to health insurance and behavioral health. So this is, again, me understanding, and one thing we always talk about is the ability to use proxies, right? So health insurance coverage, I asked individuals, what type of health insurance coverage do you have? And based on that, I can know approximately, right? This is just a proxy, whether someone is U.S. citizen, right? Because otherwise they would have probably a public insurance. And then moving on, also, do they also have, are they eligible for public services for low income? So based on that, I can understand a little bit more about their immigration and economic status as well. And then moving on to behavioral health, we talked about a couple components. Do you prefer talking to a counselor versus a specialist? Do you rather go to a clinic versus a, in times of distress, do you go to an ER or do you go to your primary care doctor? So understanding how people move. And then moving on to health screenings. So for my health screenings, I tested anxiety, depression, PTSD, suicide ideations, resilience, self-efficacy, and I think I might be missing one, but there were 6 overall, and you'll see that in a minute. Mostly digital, again, because of what we are with COVID-19. I actually walked the streets and I asked people, and it always surprised me that I was, in terms of outreach for my job, that I was able to talk to people easier when it came to vaccination for COVID-19 versus mental health. People get so upset just hearing the word mental health. And, that surprised me, and also included in my limitations and so forth, that there has to be a campaign that goes out at a local level to really start getting people feeling comfortable with mental health and just discussing mental health. So here are the tools I utilized, like we talked about, acculturation, Hispanic, resilience, depression, anxiety, and PTSD. And then these were the 3 major questions that I used. We'll move into it. I talked about the demographic descriptive statistics, understanding where people were. I did bivariate testing for those who are interested in statistics. I had a 5% significance level, chi-squares, moving on to ANOVA and t-test, and then binomial multinodal logistic regressions, just to get an understanding of what was happening. And my major confounding, meaning that the 2 variables that stayed consistent in all my study, all my data analysis, was gender and generations per household. Again, I wanted to see if there was differences between males and females. I did ask how people identified in terms of sex, and I did include other identities, but males and females were the greatest. And then generations per household, understanding was there 0 generations, meaning were you living alone, or was there 2 or 3 generations living with you? New Jersey is one of the states with the highest generations per household in the country, especially in the north. So these are my research questions. I'm gonna fly through them. Again, does the immigrant paradox hold consistent across mental health symptoms in US generations during the COVID-19? Again, I wanted to see, is there a change, right? Are Latinos still being resilient even during a pandemic? And you'll see my results soon. Question 2, are there differences in experiences of mental health symptoms during the COVID-19 pandemic across the 9 burden groups? As you can see here, there's a lot of burden groups, and then the 4 demographic characteristics. So you can see here, I also tested for different demographic variables. I'm not going to get into all of them because there's a lot, and that you can read my dissertation for that. Question 3, how has healthcare and mental health service utilization changed during the COVID-19 pandemic across the 9 burden groups and 4 demographic characteristics? So again, I'm studying not only mental health outcomes during this particular period, but also how people utilize the services around them. So now getting into my results, I do want to share this digital map because I think it's pretty neat. Give me one sec. Just gotta step out of this. So this is my study, where my study participants came from. I don't know how we ended up in Houston, but someone in Houston took my survey. And also someone in I think, yeah, in the Long Island. So that's pretty neat. As you can see here, again, this is New Jersey. You can see where the majority of the people took my survey, and it's really this Essex, Hudson County area. And then the individuals, like I was saying before, right? So when we talk about Latinos, you'll have the majority in North Jersey, right? Moving on to Central Jersey, you'll have some as well. But when we come to here, this area, this is all seasonal farm workers, right? So because I didn't have the funding to do and getting into these areas, because it's really hard to get into these areas. And at the same time, I started collecting data at the end of the season when people were really leaving. It was very difficult to get more people. But this is a huge community that I think needs more work when it comes to mental health, because they were the most susceptible to COVID-19 infection. So this is my study. This is my study sample. Let me go back. So now getting into the nitty-gritty of what I found, right? So I did found a directional change. So foreign-born individuals, right, were approximately 3 times more likely to report minimal depression compared to US-born participants. So what does that mean? That means that there is a directional change. That means that for my study, right, and this is for my particular study, people who are foreign-born were actually experiencing more depression than US-born participants. So, you know, again, this is huge. I obviously didn't get PTSD in the other ones, but this is for depression individuals. We did see a change in the direction of the immigrant paradox. And again, here are the controls: language, gender, generations per household. Spanish language participants were less likely to report anxiety compared to English language. Again, we're talking about these protective factors, these buffers. Language is huge when protecting against anxiety. Females were approximately 3 times more likely to report anxiety compared to males. We already knew this. We looked at the literature. We knew that was going to be, but at least we can quantify what percentage in New Jersey are more likely to experience anxiety. Again, Spanish language participants were less likely to report PTSD compared to English. So again, this is showing that the immigrant paradox holds true for PTSD when we take into account the language. And also females were approximately 3 times more likely to report PTSD compared to males. So you can see that females are going to be more susceptible to anxiety and PTSD. Now, do we know if this is because they're reporting it, or is this because they're really actually experiencing more compared to males? So for this particular study, we can definitely say that females reported more because we had a good sample when it came to females versus males. When it came to social position and mental health symptoms, essential workers were less likely to report moderate depression compared to non-essential workers. So this is huge, right? Because I was looking at who is considered an essential worker, right? So I took the US Census, I took what the policy was as an essential worker, and I coded them, right? I gave opportunity, what area do you work in? All right, you're considered an essential worker versus you're not considered an essential worker. And we saw that these individuals were less likely to report moderate depression, which is interesting, right? Because we would think that someone who is an essential worker would obviously experience more, at least I thought so, because they were more exposed and could potentially be more fearful of exposure. Uninsured individuals were 7 times more likely to report moderate depression. And again, this is huge. You know, this says a lot. We can say that, you know, in a time of uncertainty where you need health insurance because of the exposure to COVID-19, that could lead to depression, right? Insurance and not being able to provide or not being able to feel secure enough that you're going to get the quality of healthcare if you fall ill. That's huge. Individuals living with no generations at home, right, were 4 times more likely to report moderate depression. Again, talking about how having more generations at home, or having generations at home, one more generation at home, is considered a buffer as well, right? Especially during times of hardship. Females are less likely to report moderate depression compared to males. We already talked about that. Individuals below the national poverty level. So I did check the national poverty level, and I said, all right, based on what you're reporting here, if you are below $1,074 monthly, you are considered below the poverty level. There are 6 times more likely to report low self-efficacy. So again, self-efficacy means you're able to navigate through a system. No matter what, you're going to come on top, right? Because you believe you are able to do so. And and then individuals also who fell below the national poverty line were 18 times more likely to report low self-efficacy. And again, when we're controlling for health insurance coverage, educational attainment, generations per household, and gender. So that's huge, man. It's incredible. When it comes to COVID-19 and mental health symptoms, this is again for every 1 increase in COVID-19. So I asked individuals how many people were infected, or how many people were infected in your household, right? Or in your workplace. So this is what I found. Household and workplace had the biggest outcomes. Household infection, there was a 1.3 odds ratio increase in anxiety. It also increased anxiety among females by 2.5 odds ratio increase. So the more people infected, the more this happens, right? Workplace hospitalization, 1.4 odds ratio increase for PTSD. And then moving on to when we control for generations per household and gender, 1.6 times for suicide ideations. So that's huge, right? So we know that what's happening in the household and what's happening in the workplace lead to these type of outcomes. Now, when it came to hospitalizations for family members, right, we saw a decrease in normal resilience, right? This is the resistance, the ability to feel like you're gonna come on top. Workplace related hospitalization, we saw a decrease again in normal resilience. So as people are being hospitalized, not only in the family, but also in the workplace, that decreases the resilience. People get, lose resilience. And then moving on to workplace related deaths and also work related deaths, you can see here 1.7 leading to PTSD and 2.2 ratio increase when we control for generations per household and gender. So again, the workplace is a key component when it comes to outcomes, mental health outcomes. Now, when we found for health service preference, utilization, and simulation variables, as you saw the simulation variables in the text before, I found 6 major findings. One is, as US generations increased, there's a willingness to use over-the-phone healthcare increase. So one of my areas is telehealth for research. And you can see here that, that happens, which we kind of understood, right? More generations here, more technology-based, and so forth. The willingness to use clinic-based services decreases as well, right? Individuals will use more specialized health services. Also for nativity, we found that foreign-born individuals were less likely than US-born individuals to use mental health services pre-COVID-19. We knew that. Females were 4 times more likely than males to use mental health services pre-COVID-19. So again, I'm testing what literature is showing me, but at the same time, I want to know specifically to New Jersey, what's happening, right? And how many times more. The acculturation, right? Basically, are you more dominant in non-Hispanic or Hispanic culture, right? So individuals with the highest assimilation were nearly 7 times more likely to receive an annual physical, meaning that these individuals were the most dominant in the non-Hispanic culture. And then females were 5 times more likely to receive an annual physical compared to males. So that's huge, right? Moving on, I know there's a lot, but I like I said, I did a lot. I spent many months coding and checking every which way to see what I found. Uninsured individuals were more likely to prefer primary care services compared to uninsured individuals. I thought that was so crazy, so crazy. Females were more likely to receive annual physicals compared to males. We know that. Individuals residing with one additional generation were less likely to prefer remote services. You know, this is just a finding. You can interpret it every which way you want. I always wonder why that is. Females were more likely to receive mental health services pre-COVID-19. Again, we knew that already. So this is the end. This is showing all those results. Again, the conceptual framework in the bold is what I found in terms of findings. In the gray is stuff that I didn't find any statistical findings, right? So I didn't study it. So I didn't find any outcome or any associations or correlations between education and mental health outcomes, social cohesion, social capital, living with working conditions. So you can see here what I found. Like I said, I plan to publish in the coming months and get the word out of what's happening. But for now, I'm curious to hear your thoughts about the findings. You know, how's everybody feeling? I know we're coming out of almost 2022. 2023 brings new opportunities. You know, I don't know if anybody here has experiences that they want to share about COVID-19 and how it impacted their family and how they're using mental health services or not using mental health services to heal. So I'll open it.
Thank you, Nayeli. Definitely, this is great information, super interesting and eye-opener. We had no idea. Congratulations. Excellent job. And we have a question right here saying, according to your perspective, right? Obviously, this is, I think, a tough question, but for how long do you think we will be seeing the effects of the pandemic in terms of mental health? Obviously, that's a tough one because now we have so many variations. Go ahead.
Yeah, so we were talking about this yesterday, right? We were saying that when we go through traumatic experiences, we won't see, well, according to literature, you won't see the impact 5, 10, even up to 20 years after the experience, depending on what's happening and who the person is, right? So I think it's not a one answer, but I think that the biggest thing that we can do is just keep in mind of what's happening with ourselves and taking care of ourselves, right? Being, I don't want to say selfish, but being mindful of, do I need time to heal? Do I need downtime? Do I need to see somebody? Do I need to talk to someone? How is my family? What's happening to them? I can tell you here that here in New Jersey and in New York, my family was hit very hard with COVID-19, especially in Rockland County, New York. So as you know, it's like the next county over from North Jersey. And my grandmother was in the hospital for many, many months. She was intubated, not once, but twice. You know, she's close to 80 years old. And she survived. She had 5% chance of surviving, but those, you know, those months and even after she, you know, got off the intubator and was recovering, it hit my family hard, physically and mentally. You know, I'm lucky that I have family who are in the medical field who were able to assist. But at the same time, you know, it was hard. And if I look up a picture of myself now versus a picture before the COVID-19, I look like a different person, you know. What the stress does to you. And, you know, we're talking about allostatic load, meaning like the stress hormones that are released in your body, the, you know, quarantine, the sitting at home, the remote, what that does to your body, but also to your mental health, you know, is not like other, right? So like I said, 2023 brings in opportunities, and I hope that everybody has a plan to become healthy again, that, you know, goes back into the world, networks, sees each other, because I think one of the strengths, like you were saying, that Latinos have is the collectivism, right? Is the also the family, being able to have large families, being able to see people from your community as compadres, primos, everybody. I always laugh because un mexicano siempre es un primo, right? So we always want to help them out. So no matter what, who they are, you know, we want to take care of our community. And I think that's where we are right now, is how do we take those stress buffers, those protective factors that are already part of our culture, and implement them to get healthy physically and mentally post COVID-19.
Thank you, Nayeli. Let's see if anybody else has a question. If no, we will just recap. Gilberto, go ahead.
I don't necessarily have a question. It's just more of a comment and an observation. Here in Indiana, at least where I live in the region, we are the RV capital of the world. So recreational vehicles, RVs, and, you know, in Spanish they say, aquí la gente nunca dejó de trabajar.
Yeah.
Aquí la gente, mira, todos los días a trabajar. Y el problema que tenían es que, como todo el mundo en el trabajo, pues todo el mundo a bailar después del trabajo. Y entonces eso también causó problemas con muchos que se enfermaron, porque pues se veían todo el día en el trabajo y luego por las tardes pues ya se iban todos al baile o a la fiesta. Y así que no culpa de ellos. Sin embargo, que la industria, los que manejan la economía aquí en esta área, pues para ellos lo más importante en ese momento era sacar el producto. Y perdimos a mucha gente, y perdí a un buen amigo, Álvaro Márquez, dedicado a la comunidad, al trabajo, de todo, ¿no? Cultura, tremendo líder. Y mucho de eso, pues creemos, pues el hecho de que la industria exigió que mucha gente, vino la CDC aquí a la comunidad, y se encontró que los latinos tenían más casos, tenían más problemas emocionales. Y creo que lo importante de tu estudio, Nayeli, para mí es que ayuda a la fuente de investigación, empezar a determinar cuáles fueron y cuáles han sido los efectos del COVID con el pueblo, y que creo que van a haber más y más estudios. Así que vas al frente de varias personas. Así que te felicito por tu estudio, y pues espero que podamos conectar, y me encantaría conectarte con la doctora Alegría para que ella pues sepa de tu estudio, y pues ustedes están ahí cerca en la área pues para que puedas hacer un viajecito allá a la Universidad de Harvard, y pues que te conozcan, y tienes un futuro muy brillante, y te felicito.
Muchas gracias.
Muchas felicidades, Nayeli, de verdad. Y la verdad que pues la pandemia dejó muchas pérdidas, pero también dejó cosas positivas. Soy extraño, pero es la realidad.
Sí.
A muchos nos cambió para reordenar y las prioridades, arreglar nuestra vida. Yo hice muchísimos cambios en mi vida personal y profesional. Entonces, para cerrar, sí me gustaría que nos compartas tu opinión respecto a lo positivo. Ejemplo, the essential workers. O sea, ellos siempre han sido esenciales e importantes para la economía, son el motor de este país. Pero nadie sabía o nadie les daba el lugar, ¿no? Por ejemplo, entonces tuvo que pasar algo malo para que resaltaran. Entonces, desde tu perspectiva, ¿qué consideras que es algo positivo?
Claro. Lo más importante de mis estudios o de mi investigación, de mi educación y también de mi activismo y también mi trabajo dentro del gobierno, siempre ha sido tener información para empujar al gobierno, ¿no? No hay muchos latinos en el gobierno. Yo trabajo para el gobierno del estado de Nueva Jersey, en el Departamento de Salud. Mi función principal ahí es creé un programa dedicado al alcance para personas que son inmigrantes y minorías, básicamente los afroamericanos o la comunidad negra, right? La comunidad afroamericana, y también puede ser comunidad africana, comunidad caribeña, afro, ¿verdad? Y también latinos. Entonces yo creo que no solamente con mis resultados de mi investigación, sino también con mi trabajo, hemos podido aprender muchísimo de cómo las comunidades consumen información en términos de salud y también cómo podemos hacer estrategias, ¿verdad?, para crear redes de comunicación si algo pasa de nuevo. Y no solamente tiene que ser un desastre de salud pública, pero también natural. Por ejemplo, en Nueva Jersey tenemos muchos huracanes, ¿no? Entonces, ¿cómo podemos tener un estado que ya sabe cómo comunicarse y cómo llegar a un plan de emergencia cuando suceda? Otra cosa que pudimos hacer a través de mi, digamos, activismo, tener esos resultados y crear reportes para que el gobernador sepa lo que está pasando, ¿no? Entonces, a través de estas cifras, a estos datos, se puede crear nuevos programas de intervención, nuevos programas que sean fundados directamente del Estado y también de departamentos federales, por ejemplo, el CDC, ¿verdad? El CDC funda mi programa de COVID-19, que es el COVID Community Core. Este programa lo creamos en marzo y en junio de 2021 el gobierno federal lo tomó como modelo y creó su propio programa basado en nosotros. Entonces, creo que Nueva Jersey somos, como estaba diciendo, somos un estado pequeño, pero tenemos muchísima personalidad. De hecho, la vacunación de COVID-19 salió de aquí, de Rutgers University, un profesor que lastimosamente se murió, pero tenemos muchas mentes brillantes que creo que a través de nuestras redes, estábamos hablando de esto antes de que los participantes vinieran, pero a través de becas, a través de redes y digamos conexiones con otras personas, podemos crear más, ¿entiendes? No solamente como latinos, pero como mexicanos, que somos la comunidad más grande de los latinos en los Estados Unidos de América, ¿no? Tenemos un gran poder o potencial poder político y también en investigación y salud, ¿verdad? Porque lo más importante, y siempre he dicho esto, sin salud no tenemos nada, no podemos trabajar, no podemos ayudar a nuestras familias, ¿verdad? Entonces necesitamos salud y necesitamos personas que son capacitadas en cualquier área, no solamente, digamos, una formación tradicional como la que he hecho hoy, pero tenemos que tener personas que es una comunidad especializada que pueda ayudar en momentos donde tal vez el gobierno no puede, ¿verdad? O tal. Pero yo creo que eso es todo, que hemos aprendido muchísimo y hay que implementar todo lo que aprendimos.
Excelente, Nayeli. Gracias por ese cierre tan interesante. Quiero agradecerle a todos los que estuvieron el día de hoy con nosotros en el chat. Si quieren saber más actividades acerca de la organización AMA USA, por favor sigan las redes sociales. Por nuestra parte, con esto estamos cerrando la serie de webinars del comité de AMA Women. Les invitamos a que sigan las redes sociales. Vamos a hacer un cambio. Bueno, Johanna, no sé si quieras dar como que de heads up. Tenemos aquí a Beatriz. De hecho, nos está acompañando. Quiero públicamente darle las gracias a la mesa directiva de AMA USA por la oportunidad de haberme dejado liderar este comité de AMA Women. Y viene una amiga querida para el próximo año, Beatriz, que está aquí. Pues vamos a estar todas en buenas manos. Yo seguiré colaborando, pero ya con otro liderazgo estamos aquí. Entonces, Johanna, te paso la palabra.
Gracias, Ceci, y muchas gracias por más de un año de liderazgo, de trabajo, de una serie de webinarios donde aprendimos muchas cosas de todos los temas, desde educación financiera hasta salud mental hoy, cómo participar como latinos, como mexicanos en la política, muchos temas muy importantes para nuestra comunidad y que los invito a que nos sigan en redes sociales, a que vean los seminarios de AMA Women que están en YouTube y que compartan con sus comunidades para que sigamos aprendiendo juntos. Y también darle la bienvenida a Beatriz como nuestra nueva chair, presidenta del comité de AMA Women. A partir del año que viene, que estamos seguras, vamos a continuar con muchos proyectos como lo hemos hecho hasta ahora. Muchas gracias, Beatriz. Y gracias nuevamente, Esi.
Un placer y
Sí.
muchas gracias, Beatriz, por
Me uno
todo lo que viene.
a los aplausos. Todo un orgullo seguir en el trabajo que tú de una manera tan excelente nos has guiado. Así es que bendiciones. Sabemos que te tenemos ahí y que vas a estar a un lado también aquí aconsejándonos y apoyándonos. Muchísimas gracias y por supuesto quiero lanzar una invitación para que todos nos sigan y también nos den sus propuestas de cómo quieren que se dirija todo esto que está ocurriendo en AMA para el próximo año. Muchísimas gracias a todos.
Gracias nuevamente. Y como ya huele a posadas, pues estamos cerrando el año prácticamente. Les deseamos que pasen unas muy felices fiestas, Thanksgiving, Christmas y demás. Y sin más, pues seguimos en línea. Muchísimas gracias. A nombre del comité de AMA Women, síganos en todas las actividades que hace la organización y un abrazo a todos. Hasta luego. Feliz noche.